Well, good morning. I'm Larry Field. It's a pleasure to be here, and I did want to thank Smith and Nephew for this opportunity for the fellows. I think it's a great and timely period of time in your fellowships to learn some basic and maybe even some more advanced things, and it gives you guys an opportunity to interact with some of us, and I'm glad to participate. So I've been charged with giving two talks back to back here, so bear with me over the next few minutes, and they're both related to rotator cuff tears, and they both hopefully kind of dovetail into one another. And so I'm happy to communicate with any of you guys afterwards as well about any of the questions that you might have. So the first talk is on the evaluation of partial thickness tears. Well, partial thickness rotator cuff tendon tears are interesting in part because despite the fact that they occur very commonly, we see them on a daily basis, those of us that do shoulder surgery, identifying those partial thickness tears either with MRI or arthroscopically even can be difficult. And even if we adequately recognize the tear, defining the extent of that tear is not easy. It's not easy. It can be much more extensive than it may appear to be on the surface. And finally, if we identify it, if we define it, then we still have controversial treatments regarding what to do with it. And just in brief review, rotator cuff anatomy, of course we know the supinatus and infraspinatus assert and that greater tuberosity. What's important about the anatomy of the rotator cuff, especially with partial thickness tears, is the anatomy, the footprint itself. And we know that the footprint for the supraspinatus is about 12 millimeters, the infraspinatus about 13 millimeters, and that's really important to have in our brains because we have to know what percentage of the tear is represented when we measure these tears. Also, the rotator cable, this thick band of cuff tissue that spans the supra and infraspinatus tissue, it shields the crescent, and the supraspinatus inserts here. Now, what's also very important if we're trying to define the extent of a partial thickness tear is understanding where normally the rotator cuff inserts on the greater tuberosity. And the supraspinatus inserts basically immediately adjacent to the articular surface, as opposed to the infraspinatus, which inserts about 6 millimeters away from the surface. So here's a video, hopefully I'll show that. There's our supraspinatus. See how it inserts immediately adjacent to the cartilage? But look at the infraspinatus. It's significantly distant from the articular surface. And this really matters when we're trying to assess whether there's a partial tear and how big the partial tear is. So the causes of partial tears are either intrinsic or extrinsic. In etiology, they're associated with age. In cadaveric studies, both large studies from years ago, they found that partial tears are indeed common in this cadaveric study. Ellman in 1990 originally graded these tears as less than 25% detachment being a grade 1, 25 to 50% grade 2, and a grade 3 greater than 50%. Snyder subsequently further defined these partial tears as articular or bursal and a severity score as well. So we've got two types of tears. We've got an articular partial thickness tear and we've got a bursal partial thickness tear. It's generally thought that articular tears are degenerative in nature. There are articular-sided tears which are secondary to internal impingement, this overhead athlete repetitive contact injury that we're not going to spend a lot of time on, but suffice it to say that they're not uncommon in that patient population. Bursal tears are generally attributed to an outlet impingement, and then you've got intratendinous tears that are due to traction, tensile overload, but also degenerative causes as well. So clinical assessment of patients with partial thickness tears, well, pain's the most common symptom, just as it is with full thickness rotator cuff tendon tears. And physical examinations, typical again for what we might expect in rotator cuff pathology, positive impingement, and then those micro instability internal impingement patients, maybe some other findings specific to that, like internal rotation loss. How do we image and identify and recognize these preoperatively? Well, MRI has been shown to be difficult in reliably showing these partial thickness tears, and MRI has been demonstrated in studies to have improved accuracy. Specifically, this ABR view, this abduction extortation view, can improve sensitivity in these tears, and maybe an MRI is prudent when the diagnosis is in question or when symptoms suggest a partial thickness tear, and it's very important maybe to recognize that preoperatively. So once we identify or suspect partial tears, non-operative treatment, just as it is for most cases of rotator cuff tears, full thickness tears, is non-operative. For internal impingement patients, some specific rehab exercises such as sleeper stretches, stabilization exercises may be valuable. So if we're going to operate on these patients because of non-operative failure, then it's obvious that we want to debride all the partial thickness tears that we identify. That's kind of a no-brainer. We all recognize that. But after we debride these tears, which tears do we repair? And if we choose to repair the tear, how do we do that? What technique do we use? Do we complete the tear and repair it, or do we do a transtendon type repair? And how do we manage subacromial reaction with acromioplasty, et cetera? So decision-making for partial thickness tears is important. And there are several, I think, important factors to consider here. One is, of course, how deep the tear is, and we're going to talk more about that. Whether it's an articular-sided or bursal-sided or combined tear, the patient age, activity level, and associated pathology. And using this little marking suture is something we do on a daily basis in my office when we recognize, in surgery, when we recognize these partial thickness tears. I think it gives us a really good opportunity to assess the adjacent bursal cuff tissue and make more informed decisions, I would argue. Again, we want to measure the depth of the tear. Again, as this screenshot from that video I showed earlier, we know the normal cuff inserts in the supraspinatus immediately adjacent to the articular surface. And once we debride that partial articular-sided tear, we want to measure that tear to get a sense, based on our knowledge of how deep a normal footprint is, of what percentage this represents. Tears that are shallow, let's say less than 3 millimeters, generally in the literature have responded adequately to debridement. Acromioplasty maybe for bursal-sided tears that are superficial. Larger tears, though, may require repair. And in an early study many years ago, Yamanaka found that 80% of 40 articular-sided partial thickness tears progressed arthrographically in his study. One of the techniques for repair these partial thickness tears that we elect to do so for is this transtendon or pasta-type repair. And there are requirements that I think need to be respected if we're going to use this technique. One is there needs to be an adequate amount of remaining intact tendon, maybe 25% or more. It doesn't make a lot of sense to me, at least, to reattach a very thin sliver of remaining unhealthy cuff tissue. That patient may be better served with completing the tear and repairing it. Gonzalez, though, in 2008, in a cadaveric study where he created these 50% tears, found that transtendon repair was stronger than in those patients that he completed the tear and repaired. It's important, too, of how we reapproximate the footprint when we do these operations. We don't want to over-lateralize the footprint repair, and there's often a defect of tissue there that we need to be cognizant of when we repair these. But suffice it to say that it's pretty straightforward. We make a very thin split in the torn partial thickness tear. We place anchors along the anatomic footprint and then can retrieve sutures using whatever device. And if I pull on this suture, you can see how we can and will reapproximate it to the anatomic footprint. And then we can find those sutures in the subacromial space and tie knots as shown. So here's another example. I just want to demonstrate to show this, the importance of identifying and recognizing these tears. If we do kind of like this cursory view, we see there's a little sliver of a split there in the supraspinatus. It's probably relatively superficial, and yet it's not. And I think that we want to be very diligent and deliberate in how we debride these. You can see that that's effectively a 95% plus partial thickness tear that on the surface at least look to be relatively superficial and shallow. What about bursal tears? Well, the articular surface is typically left intact if it's healthy, and often in these patients, interestingly, the glenohumeral joint diagnostic exam will be completely normal. It'll look completely normal, and it's only when we get to the bursal side that we recognize these tears, and we've got to be diligent again to not to miss these. We saw one yesterday that really hid from us significantly, and I had to do it all by myself because my fellow's here. He wasn't with me, so it's just a shame. But honestly, they can hide from you as well, and anchor technique typically for those patients. And here's an example. You know, at first it looks like pretty normal cuff, but you can see when we probe this, this very large but bursal-sided rotator cuff tendon tear, completely normal glenohumeral joint, and we could overlook this tear in the bursal side if we're not careful. But once we recognize these, we can debride them, we can debride a tuberosity, and we can use anchors and sutures just like as we would for any tear. And, I wish all of our rotator cuff tears were this easy to fix. That'd be nice, But I guess if they were this easy, maybe the radiologists would do them in the radiology suite, so we probably should be glad that some are more complex. Lastly, intertendinous tears, they're a challenge. They're a challenge because MRA often won't show them. Sometimes you just have to probe the cuff in a very deliberate way again to help recognize these, but they do occur, they can hide from us, and they can cause symptoms that can be improved significantly with repair. So if we look at the results briefly on partial thickness tears, we know, interestingly, from studies that partial thickness tear debridement does not prevent progression. There are a number of studies that show progressive tearing of partial thickness tears even after arthroscopic debridement. We know, too, that trans-tendon repair and completing and repairing those tears provide good outcomes. And in this comparison of two repair techniques in a prospective randomized fashion in 2012, they looked at two groups, 24 in each group that had greater than 50% partial articular tears that they repaired on one of these two techniques, and found that postoperative MRI showed good healing rates in both, and there were no functional differences in that. And also, in a systematic review of the literature in 2011, they looked at 16 studies evaluating these partial thickness tears as it pertains to debridement, repair, and the different techniques for repair, and found that for superficial type tears, that debridement, while we know they may progress, at least in the follow-up from the study, showed that these were successful outcomes. And lastly, these partial thickness tears that are greater than 50%, the repair is successful regardless of these two techniques. So in summary, very careful arthroscopic assessment is important to identify the presence of these tears and to define the extent of the tear. We know now that significant partial tears do not heal and often enlarge in the literature that's available to us. And for partial tears that are greater than 50%, I think it's important to consider repair. And we know that both repair techniques, a post repair or a complete and repair, are both successful. So I want to, in a very short segment, show mistakes that I've made treating partial thickness tears. 3 short videos that hopefully will help you guys in managing partial thickness tears. The videos actually are some of my fellows, mistakes. No, I'm just kidding. It's my mistakes, or it's my simulated mistake that hopefully will help us to recognize how to avoid problems in dealing with partial thickness tears. And I've called these errors 3 technical errors. Number 1, I call careless driver. Number 2, tunnel vision. Number 3, poor marksman. And so with regard to careless driver, it's important, obviously, as I've mentioned, to thoroughly assess these tendons for rotator cuff tears. And it's especially important, I think, when we have a low expectation. So here's another example. If we look here, it looks basically completely normal. There is a little tiny poke hole there, but if I debride that away, it becomes very obvious that what was hiding behind that tiny little hole was a very large partial thickness articular sided tear. So we want to be careful, and we want to be very deliberate in debriding these and go through the capsule. That's not the cuff, that's the capsule. And we go through the capsule. We recognize that behind the capsule is a cuff pathology that we may or may not recognize, and it was effective. They can drive right in to that defect that's present that, again, initially wasn't visible. Number 2 is tunnel vision. We want to make sure that if we identify these partial thickness tears, that doesn't conclude our diagnostic assessment. We can see these tears and recognize them, and it's easy to logically assume that that's the cause of the patient's shoulder symptoms, but it really isn't necessarily so. A lot of these articular-sided or bursal-sided, or particularly articular-sided tears, are asymptomatic and just happen to be there, and they're very common as patients get older. So here's an example of that. Here's a supraspinatus partial thickness tear. I've identified it. I've defined it. I've dutifully used my PDS marking sutures so I can recognize the cuff on the other side, and I can get a good assessment of the other side of the cuff. And so I'm really kind of proud of myself because I've done everything that I need to do. And here's my Here's my PDS marking suture. It looks pretty good on that side, and so I think probably I'll just debride that. But the reality is that probably has nothing to do with this patient's symptoms, because he has a large bursal-sided partial thickness tear completely distant from that articular-sided tear. And so we don't want to get tunnel vision, and once we identify partial tears, think that's the end-all of our assessment. Lastly, again, I think this PDS marking suture is very important, but what's also very important about it is the orientation that we put that PDS marking suture in. We want to be in line, in parallel with the suture fibers, because the goal is to get that PDS marking suture on the bursal side as close to the articular side of the tear as possible. We don't want to be remote from it with our marking suture. And so I simulated that here in a patient. This is a partial thickness tear. I'm going to place a PDS marking suture. In fact, I'm going to place 3 PDS marking sutures all coming in at the same location, but oriented very differently in the subacromial side. So you can understand that if we elected to complete this tear and repair it using a complete technique, coming in obliquely would cause, I think, a lot of unnecessary iatrogenic insult and really not unroof that partial thickness tear necessarily. So bring that suture in appropriate orientation. Thank you.